Thanks to the organizers for inviting me. Thanks to allow me to share the podium with a true pioneer, Dr. Oakley. And also thanks for confidence that I have anything useful to say about the future of our specialty. It's an interesting task when you're given to talk about the future. And I want to illustrate that with this fun little vignette. So this is a screenshot from the film Blade Runner. I don't know how many of you have seen it. It's old now. It's a classic though. But when it came out in 1982, I was a medical student, and I went with a bunch of my buddies to see this film that was supposed to be in 2019. So it's come and gone now, and we can go back and see how accurate any of it was, which I think is always a fun exercise. Now, of course, it's science fiction, so there was a lot of perhaps overdoing of the future. But this illustrates, I think, one real interesting aspect. So on the left, you see the main character was played by Harrison Ford. And on the right is an image of a woman that he was in love with. And he was, during this scene, he's in a bar, he's having a drink, he's lonely, he wants to connect with this woman. And so he goes and makes a video call, which I have to tell you, in 1982, that was just pure fantasy that you could do that. Of course, now we do it every day. But, so they got that right, but he goes to a phone booth to do it. So this is the challenge of predicting the future. You get half of it right sometimes you completely miss. And so I use that as a disclaimer before I give my remarks. Now this to me, and by the way, I said US perspective, I glossed over that only because I don't feel it's presumptuous of me to know really what it's like in other countries around the world. But I suspect that most of this will resonate with most of you. And to me, this graph is both the reason that we must innovate, and it's also the drag on innovation. So let me explain that. So you see the top headline that by 2050, the workforce will be 25% below patient demand. I think it's probably there now, to be candid with you. It's every dermatologist I know has a 3 to 6 month wait. Waiting is always full, we're busy. So I'm not sure why it's 2050, but we can even take that, sure. And as you can see on the curve, which the curve is for medicine in general, but as I said, it applies to dermatology for sure. It's based on a couple of premises, and one of them is that in order to conduct care, as the picture in the background illustrates, you have to be in the same room with someone at the same time. So it's a one-to-one interaction. Since the pandemic, everyone's very comfortable now, and many of us were beforehand, doing this with a video call, but that still ties two people up at once. So what we really need to do is find tools that can enable the same number of clinicians to tackle the demand more effectively, what I call one-to-many. And my remarks in the future, as it pertains to the US, are going to hinge on this notion of whether we in traditional healthcare delivery can bring ourselves to do that, or whether it's going to be disruptors. So I said this is both the reason for innovation and the reason there's a drag on innovation, which is just what I said. Every dermatologist has a long wait time. They're doing just fine in the office. Why would they adopt anything new except something that maybe brings more revenue in to their standard way of delivering care? And that's sort of the next concept I want to point out, which is we have to view all of these wonderful innovations that are coming our way, and they are for sure, but we have to view them in the context of practice patterns and economics, because that's going to be the gating factor in their adoption, in my estimation. So I look at it really in terms of three kinds of buckets for these innovations. One is innovations that increase provider revenue, like a new laser in your practice, a new filler, a new kind of thing you can do that will bring more patients in, that will enhance your financial capabilities. Those do pretty well. They get pretty well adopted. I have a similar talk on this that I do for general medicine, and I compare telehealth with minimally invasive surgery. And minimally invasive surgery has kind of been around for about 25 years now, but by 2020, everything's done through a scope. I've been doing in the teledermatology world since the mid-90s, and we're still not close to our capabilities because it's more disruptive than something like minimally invasive surgery. So the same concept would apply here, that you can, some of the things I'm going to talk about, and I think digital scribes is a perfect example of one that's going to be, we're going to get that. No, you can check that box because it makes everyone's life easier. It's the second category here, which are innovations that are increase efficiency. Now, the first one is the best because it brings in revenue. The second one is good because even though you have to pay for it, you're going to get something of value out of it. And again, it could be you just go home and you don't have to write your notes, and that's valuable to you. You're willing to pay something for that. But the third category, and most of the rest of my talk is going to feature that third category, are innovations that are just disruptive to the way we deliver care. And they have this drag on them, like I said, of why would I do anything differently? Life's pretty good right now. Why do you think I should do any of this? So let's just look for these under that sort of spotlight. And the categories are, well, telehealth. I'll spend some time on telehealth because it's just a base, used to be the conference, used to be called the telehealth conference. There are these improved imaging tools for patients. Again, that means maybe patients be able to get some information they need and not come to see you. That's disruptive, even though you have a 6-month wait. And then various other kinds of aids to patients, whether it be or referring clinicians, whether it be tools that enable a primary care doctor to triage better, which again has been mentioned already, et cetera. So we'll go over some of these. And as I said, most of these are going to have, in my opinion, slower adoption curves because they're at odds with that very busy but comfortable practice that most of our doctors are in. Now, the wild card could be that this all will happen. It just won't happen within standard care delivery. It'll happen outside. And there's some examples of that I'm going to share that are already giving us a glimmer of what that might look like. All right, so let's just do teledermatology. Now, I follow telehealth adoption since the pandemic. I followed it using a website called Fair Health. And what they do is they capture, and not just for telehealth, but they capture the number of healthcare claims for any given condition. This happens to be their telehealth page, and I know it's a busy slide, but I'm going to walk through it quickly and give you the highlights. So at the top right, you see the percentage of claims for a given month. This is all over the US for all healthcare interactions that are telehealth, about 5.5%. That's been stable since January of 2021, very stable. Before the pandemic, it was 0.19%. So it's been a huge lift, but it's just very flat now. Left of that, the specialties, social workers the number one. Left of that is all about behavioral health. 70% of that 5% lift is behavioral health. And then there's a lot of, little bits and that, but no, dermatology is nowhere on the slide. We're not even mentioned. We're not close. Why? Because people can come in the office. Why would I do anything differently? So that's standard healthcare delivery and the dermatology. Yes, I'm sure everyone in the audience is doing some. I do sessions on Tuesday afternoon. It's just not a meaningful dent right now in the overall picture. And I think that's because, again, we have the luxury of saying, come in the office. For 3 months of 2020, we didn't have that luxury and this whole thing blossomed. And of course, there's the other thing that you'll be saying, which is sometimes people do need to come in, they need a biopsy, they need a procedure, et cetera. And that clouds a little bit the use of teledermatology for sure. So is this concept of virtual first going to be kind of the next thing? Now, I want to be candid. I'm an advisor to Piction Health, so that's a conflict that I have, and I will share one slide from them. Not because I think they're doing anything in particularly better than anyone else, but this is a new concept. And in their case, which I'll share now, they're using an artificial intelligence algorithm in the background. Patient sends in images and some history. The dermatologist, as you can see here, is about 15-fold more efficient because they have the AI algorithm tee up the possible response in the same way I think that many radiologists use this tool set now. And then an advanced practice provider actually is the one who goes and talks with the patient and makes the clinical care. So will this work? I don't know. They're expanding. It's too early to tell. Is it going to be part of our future? But to me, it's an interesting way to combine that other set of activities, which I'll cover in a few minutes, which are purely patient-based over the internet versus in-office dermatology, and somehow bridge the two. And I mentioned as well that there are other SkyMD first term, so there are other examples of this concept. And by the way, for all of these, your first touch is virtual, but if you need a dermatologist, there's backup. You can go in the office and see someone. And of course, this gets offered to insurers at a lower price than standard care. So that's part of the reason it's attractive. So lots of barriers still. Barriers were always my least favorite slide whenever we talked about telehealth. And I'll just, again, for the sake of time, I'm not going to read through this, but you know, there are imaging tools. I don't know how many of you still get paper checks in the mail. I occasionally do. And you can use this thing on your phone to take a picture and send it to your bank. Why can't patients use that same tool to take pictures of their skin? It's quite good. I don't know why. Probably because we haven't had enough market need. But as was said in some of the resin presentations, lousy photographs, and Dr. Oakley as well, lousy photographs are a big issue. In the US, the reimbursement marketplace or the reimbursement landscape now is a complete disaster. We're waiting for Congress to pass a law to extend the Medicare flexibilities. That's within the month. If that doesn't happen, we'll go back to the pre-pandemic days of which seems like it's not possible. So God willing, that will happen. But even then, it's always like a year or two up, and that's hard to plan around. We talked a little bit about privacy security as well. So again, go through these. So there are limitations. And as I hinted, though, I think if we were to wipe all these away, I'm not sure how many average practicing dermatologists would then embrace teledermatology. I'm just not sure. Quickly now, some imaging innovations. I'm not an imaging expert. I wanted to mention this because these are tools and some of the, again, resident presentations. Dr. Oakley mentioned some of these as well. But these are tools that are out there and they're growing in their ability to do work, optical coherence tomography, and reflectance confocal microscopy are two examples. I think the challenge with these is how do you get the device into someone's office so they can actually use it? Who covers that cost and why would they want to? So we'll talk in a minute about DermaSensor because that's an example that, again, enables the primary care doctor to potentially triage better than they could without it. But again, they have to invest in that, and will they? And it's an open question. Now, AI, just one slide very quickly. This whole conference seems to be about AI, and it is mind-blowing. I think the one thing we can all agree on is that we're at the infancy of this technology. When I think back to when I started doing teledermatology in 1993, a 1 megapixel camera was the size of a shoebox and cost $12,000. So if you just picture that, and instead of making it 30 years, make it 5 years because of the movement, as was said earlier, of the technology. All that stuff that we were hallucinations, all that stuff's going to go away somehow. So yes, I think I could put a flag in the sand to say we're going to have a lot of AI in our practice. Is it going to be just virtual scribes? Is it going to be helping patients? That we'll have to sort out because again, market forces will determine a lot of how that gets adopted and when. But it's out there and it's already good. It's going to be much, much better. So I mentioned DermaSensor as an example. I like this example because it follows an example which is in the ophthalmology space by a company called Digital Diagnostics, and I know that company well. The ophthalmology example is it enables a primary care doctor to assess diabetic retinopathy. So the patient puts their chin in what looks like an autorefractor. It takes pictures of the retina. and uses an AI algorithm to determine whether there is a retinopathy and whether it's worse and whether they need to go to an ophthalmologist. That company, and so that's interesting, but the way they've gone about attacking the market, they have FDA approval and they have a diagnostic code. So the primary care doctor can implement this and bill for those sessions in the way they could bill for doing an in-office strep test or something like that. I don't think, though, that it's gotten a lot of traction in the market yet. I'm not aware, I don't know for sure. It's a big device. I'm sure there's a lease plan, et cetera, that's complicated. And maybe for that little bit of extra revenue, it's not worth it. I'm not sure. DermaSensor's halfway there. They have the FDA approval. They don't have the code yet. I don't know if they're looking for a code. I'm not sure. But again, you wonder which primary care doctor or advanced practice provider is going to implement this if there's no particular added value to them other than helping patients out. And that's why I keep bringing up these economic aspects, because I think they're real. And I've seen them drag other innovations over the years, at least in the US. So finally, just a quick, some consumer-focused innovations. And as I said earlier, I talked about the Fair Health website and how dermatology is nowhere to be found. Teledermatology is alive and well. It's just not in our office. And it's companies like Curology or Apostrophe or Dermatologists on Call. Again, I mentioned First Derm and SkyMD before, and this is only a partial list. As far as I know, they're all doing pretty well. They're busy. Now, are they busy enough to make a profit? I'm not sure. Most of them are privately held. That remains to be seen, but it tells you again that there's that market. Remember my first slide, that the demand is far exceeding the supply. And those people, they want simple things answered. They want a prescription. They want advice on beauty. They're going around us to these other sites, which is not surprising. So again, one future you can imagine is that we in the office, we stick to things that are very medical. And a lot of this other stuff gets apportioned off. And for at least a while, we don't even know it, because why we have a 6-month wait, but maybe that eventually dwindles down. And we're sort of sorry we missed the opportunity to get more into this telehealth space. I'm not saying that is the future, it's a possibility. And then finally, again, these apps and so forth, and and Dr. Oakley mentioned several of these as well. Like I said, they're great, but they're disruptive, because that's one less patient that's going to come see you if they use one of these and it actually helps them. So you'll constantly hear about how inferior they are, and maybe they are now, but maybe sooner or later they won't be. And our patients will be playing doctor on themselves and being accurate. And again, we've missed that because we didn't think about how to adopt them in our office. So I think the future of digital dermatology, at least in the US, is pretty straightforward. If it helps a provider either be more efficient or make more money, I think you can guarantee we're going to see more of it. If it's this other category that's really putting more care in the patient's hands or the primary care doctor's hands, we've got some challenges there. And if you get back to my supply and demand curve, that's what we need to fix. We need to be comfortable offloading that care somehow while having continuity of care, while having the right EMR records, et cetera. And right now we're just ignoring it. So I'll leave you with that. I hope that's not too negative. It's my assessment. That's what you asked me for. Thank you.